All right, good morning, everybody. Welcome back to Grand Rounds. It's January 24th, and this morning we have one of our favorite rounds of the year, the Mystery Retina and Uveitis Case Panel. And I was telling you guys earlier, if it ain't broke, don't fix it. So we brought back exactly the same crew as last year. I think everyone here is familiar to our audience. We've got Dr. Paxi, Dr. Ephraim Mandelkorn, Dr. Dershko, Dr. Christakis, Dr. Ng, Dr. Kaplan, and Dr. Yoganathan. And they usually do a potpourri of cases, retina, uveitis. There's discussion from the panel. And so I will really just hand it off over to them. Dr. Bakshi, thank you for organizing these rounds for us, and the floor is yours.
Thank you very much. Good morning, everyone. We are convening again for our third time with our expert panel to go over a number of mystery cases. So first of all, thank you to the panel for agreeing to be here and be pimped again this morning on these mystery cases, some of which are quite challenging. But we hope that, even if the case is a little obscure, that there's a useful pearl that's, relevant for the general ophthalmologist or the comprehensive ophthalmologist, even if you're not necessarily doing complex uveitis on a regular basis. So we really want to highlight the discussion and any relevant pearls that, whether it's on imaging or OCT or in assessing a patient with uveitis or a complex retina patient, that you can use in your regular practice. So on that note, I'm going to begin with the first case, which is a little bit of a doozy, but I figured it's a good way to start. Okay, so sorry, Amandeep, and is everyone on now? Were you able to add all the panelists
Yes,
back?
Ephraim's on now. Yeah.
Okay, great, thank you. And so we'll start, let me just introduce the panel. Okay, so this is our amazing panel: Dr. Ephraim Mandelkorn, Dr. Larissa Dersko-Duslinski, Dr. Ken Ng, Dr. Deepa Yoganathan, Dr. Panos Christakis, and Dr. Alex Kaplan. This is the third year they've all agreed to be on the panel for the session, so many thanks to them. And it's really about their expert opinions and how they practice, when seeing these patients. So I hope we can have a great discussion and all learn together. So really, that's the main point: to have a fun and lively discussion among colleagues, to review clinical approaches to atypical presentations of disease, both retinal and ocular inflammatory disease, and really go over differential diagnoses and multimodal imaging with a really focus on practical tips. So, of course, somebody knocks at the door where I'm sitting right now, but we'll just let them wander in. But this is the first case. This is classically a text I'm sure all of us on this panel get from the resident. So Friday evening, senior resident on call. Hi, Dr. Bakshi. I know you're not on call, but I have a new patient, Bichette's patient I hope to run by you, and it's at St. Mike's. They're always at St. Mike's. So I'm sure that's the case at some of the other hospitals as well, but it's classic. And then, sure, call me, he misspelled the word me in my replying to them. And then they send me some pictures. So 29-year-old Turkish male with a sudden painless loss of vision, waking up 4 days prior, and really no significant medical history, acute loss to hand motion in both eyes, and 3+ cells in the anterior chamber and 2+ cells in the vitreous with trace haze. And this is the fundus. So I can see why the resident sent a panic text message after taking a look here. So I'll just maybe have someone on the panel. You guys can unmute yourselves if you have any thoughts on just what you see here, because it's quite dramatic.
I mean, there's pretty dramatic retinal whitening in both eyes of the posterior pole. I mean, there's some vitritis, not a lot of hemorrhage. So pretty dramatic presentation. And then the OCT shows subretinal and intraretinal fluid in both eyes.
For sure. And then also already a loss of some of the retinal anatomy, perhaps with retinal ischemia as well. And so bilateral sudden onset hand motion. So what would you guys want? What are you thinking? What would you want to do? What would your next steps be?
So I would say that whenever we have a demographic presentation, like for example, this is a young male Turkish patient, you do think automatically Behçet's because that is what our exam tests are focused on. But really, this does not have the same features that Behçet's typically does. The vasculitis looks different. It is very posteriorly focused. This looks like a very sick patient. So the first thing that comes to mind for me is porn. I had a patient in residency that looked like this and looked like the retina what had like a very finite limit of time before it could get better. So I would start an infectious workup and test for, I would do like a viral tap and test for, CMV, HSV. I would serum HIV, syphilis, TB, and start from an infectious point of view. Of course, you'd also have to keep the inflammatory conditions on your differential, but that's where I'm thinking of first.
I think that's a really excellent point. Sometimes, like, we think of it could be a one-liner in a textbook, young Turkish male with severe retinal vasculitis. Of course, we're all going to, think of Behçet's, but I think that's a really important point that this doesn't look like the typical appearance of how you see this, how posterior it is, how severe it is, and how it's immediately, within a day, infarcted both maculas. So that the severity really makes you want to think about other causes and what else is going on with this patient, not just, assume because they have the classic demographic that that's what the disease is going to be. I think that's a really important point. Panos, you're unmuted also. Did you have another thought?
Yeah, I was just going to say it's always important to remember, this is a young guy who now has hand motions in both eyes. He's in a lot of difficulty. I know that we try to manage things as outpatients in ophthalmology, but this is a patient who I definitely would recommend being admitted and getting an entire workup. Sometimes we talk about cost effectiveness and try to come up with a differential, but this is somebody who's going to need some form of treatment as soon as possible. So admitting them into the hospital gets the treatment done very quickly because all the labs and everything are expedited. And it also, allows you to get treatment and removes any kind of other variables like compliance or social issues. So this is something I definitely would recommend admitting and taking a very kind of thorough approach. Definitely, an AC tap for viral PCR, full blood work for all the infectious etiologies as well as inflammatory things, and treat based on that.
And that's a really excellent point as well. And this is exactly a young person who's suddenly gone blind. Ephraim, any other thoughts?
Yeah, just to pick up on what Deepa was saying, just the clinical features, just when you look at the images, you notice there's almost an absence of hemorrhages. And so when you think about CMV versus something like a porn or an ARN where there's arteriolitis, I mean, to separate those from a clinical perspective, CMV is usually a venous disease. So you get like a CRVO, more hemorrhagic like picture, like there's venous occlusion, et cetera. Whereas in ARN or porn, usually there's an absence of hemorrhage and because it's arteriolitis. And in this situation, it kind of looks like ARN, but it's inverse because it's posterior. So generally when you have a very posterior polar, very massive whitening with no hemorrhage, you're thinking something, VZV or HSV, and possibly HIV positive if it's posterior, or at least immunocompromised in some way. So, but I think that's an important feature to look at clinically and look at the amount of hemorrhage, and it kind of can help steer you a little bit as to which of the viral etiologies. It's not a rule, but I think in general it kind of fits with venous or arterial.
Yeah, and that's a really useful pearl as well. I think this isn't typical for, when we see somebody who has herpetic, necrotizing retinitis either. We typically see it in the periphery as well, and this is really isolated to the posterior pole. So, it certainly is an atypical presentation. That's why it's my first case. So we'll go on to the next slide, and I can't see all of you guys on the panel in the little blobs. So just feel free to unmute yourselves and chime in, because otherwise it'll take over my screen. I can't see the slides.
Anupa, just before you
Yeah.
move on, just staying with the management points that Panos was bringing up, what would you like, this is the typical of the perforation or the ulcer that we see on Friday afternoon. What would you expect? What would you want the referring doctor to do prior to handing this off to you? Or do you want us to just, hopefully we won't say this, but as soon as we see this should be a direct call. What's the appropriate management from the community standpoint?
So this particular patient came in through our ER, but absolutely, I mean, this is a very appropriate urgent referral. this would, I'd suspect that it might even come to, Retina citywide on call, and then they would call uveitis from there, because this patient has lost vision, very rapidly in both eyes. So I really, there's not really much utility to doing a lot in the community. I think this is somebody that needs to be sent in rapidly for urgent care.
So the idea would be a urgent referral as
I agree.
opposed to trying to get blood work and all that. I certainly agree with that.
Yeah.
I just wanted to confirm that that's what the uveitis community in
I
Toronto
mean,
would.
most of the time we want you guys to do labs before you send us patients. I think this is an exception.
Yeah.
Yes, for sure. So here's the fluorescein angiogram, and again, just highlighting the severity of the vasculitis and how diffuse it is, and really how focused it is on the posterior pole as well. And so I think we've gotten some important thoughts here. Admission for workup, not typical for Behçet's, but also not totally typical for virus, but really we don't want to assume it's inflammatory before we rule out that it's infectious. So that's basically what happened. So this patient was admitted urgently. He had extensive testing. He saw ID rheumatology. We did AC and vitreous tap. We started him empirically on antivirals. And interestingly, what happened though is he didn't get any better at all after antivirals, both intravitreal and systemically IV. And we saw ID in rheumatology, and we made a really tricky decision, because it could have been that we just didn't have the right bug yet, to switch to inflammatory treatment because he was progressively getting worse. So we started him again with thorough informed consent, but we switched him and started him on IV Solumedrol and then IVIG. And his workup actually came back positive for HIV. But it actually wasn't infectious. And even though he had such a low CD4 count and a high viral load, it actually is an inflammatory Behçet's-like uveitis. So he wasn't HLA positive, so it's really just based on the demographics. He didn't meet systemic criteria for Behçet's, but just an idiopathic inflammatory vasculitis in a patient who is immunocompromised with a low CD4 count. And I've been seeing him now for, I think, about a year and a half or so. He was treated for the HIV and then started on biologics. And he got to about 2,400 2 months later with extensive, at this point, ellipsoid zone loss, inner retinal atrophy, and extensive pigmentary changes. Now he's about a year and a half out now, and he can actually see about 2,100, so he's kind of functional with a phone with enlarged font on the phone and using assistive devices on the phone over time. And you can see that the disease in the macula has cleared. But, just a good example of, I think we did everything. I mean, I still think we did everything right treating this as infection. I'm glad you guys all validated that. But what is the likelihood of somebody actually being HIV positive, immunocompromised, and then actually having an inflammatory vasculitis of this severity? But just an unusual case. The patient unfortunately did not recover full vision, which I think we wouldn't expect based on the imaging that was there. But really important patient for a multidisciplinary approach and every service and urgent admission and management. And I think making that call to go from antiviral to IV steroids and IVIG was a hairy day. We were just watching him really closely to make sure we didn't suddenly make him worse.
That was a gutsy call. I mean, how long did you wait before giving him steroids?
Just a couple of days. Like he got IV antivirals. We did intravitreal injection too. Usually with intravitreal ganciclovir and foscarnet, you can start to see some improvement within a couple of days. Like some of the areas are smaller.
And I'm assuming you
I
waited
agree.
till
It was a
the
gutsy call.
PCR was negative as well.
Yeah, we waited for the AC tap to come back for sure. For sure. But I mean, obviously at this point, the patient said he's hand motion. He said, if I get worse, how much worse can it be? So I think he was pretty on board with trying anything.
Did he fulfill the systemic criteria for Behçet's?
No.
From the internal medicine perspective?
No, he
Interesting.
didn't.
That's an interesting point also. Often we see patients who have Behçet's type vasculitis, and they may even be like B51 positive, and there's nothing systemically. So another situation where we really need to decide really as medical kind of doctors, not just ophthalmologists. We need to make that call often about what do we think what is our recommended therapy, and then have those discussions with internal medicine about we have a certain presentation here in the eye that is typical of Behçet's, and we have we've ruled out the other things, for example. I mean, not necessarily in this case. And the other thing I wonder whether this, because the patient was HIV positive, whether it changed whatever presentation would have been. So maybe did that make the vasculitis so much worse, even though it wasn't a viral vasculitis? So I mean, that HIV positivity may be at play here with the presentation.
And I think that's a really great point too, Larissa, that most of the time these patients that even have Behçet's like eye disease often don't meet the systemic criteria for Behçet's, even if they're HLA positive. And, it ends up being a discussion with rheumatology as well, and trying to decide how to manage their eye. We tend to use the steroids and the biologics in the same way, but they often, the vast majority of patients with retinal vasculitis actually do not have a systemic autoimmune disease that, or meet full criteria for one.
Nuper, one point I just wanted to hop on that one is, in cases where there's diagnostic uncertainty, to really just avoid giving local steroids, like to inject steroid in an eye, even, in a case like this, there's always a little bit of diagnostic uncertainty. If you're putting someone on oral prednisone or even a pulse, these are things that you can stop. But once steroids injected, you can't really take that away. So
yes,
the point to make too.
And especially, oftentimes for toxoplasma, we'll inject the dexamethasone right away with the clindamycin. So there, you really need to be sure that it's, or fairly confident that it is toxoplasma. Sometimes patients with toxoplasma that's atypical, or they have primary toxo, and they don't have a scar, you can be confused. You're not sure exactly whether it is toxo or not. So that's a really good point, especially in these cases as well.
One nice thing though about the dexamethasone is the half-life is so short.
Yeah.
It's on the order of like a day or two. So compared to something like Kenalog, I think that's probably why they like to do that for toxo.
Yeah. Thank you, everyone. So
there's one last question here from Dr. Cates. Was the patient basically quite asymptomatic prior to awakening with hand motion vision?
Yeah.
I know it started 3 days earlier.
Yeah.
So
yes. Woke up with vision, no other symptoms.
Thank you. Great case. Great case.
So moving to the next one, this is a 68-year-old white female who, diabetic hypertension, a 1-week history of blurring in the left eye. 3 weeks prior to the blurring, had shingles on her arm and was already on Valtrex because of the shingles. So this is what her fundus photo looked like. Now, I'm sorry, these aren't the Optos images. This was during original OG COVID at some point, and the Optos camera was down and couldn't be repaired. So this is on the old school fundus camera. So these are the images that day. So her vision was count fingers. She had 360 degrees of hemorrhagic vasculitis and retinal necrosis. The photo in the upper corner there is a representative photo I've taken from the internet, but that's basically what her eye looked like. Unfortunately, we couldn't document it because we didn't have the proper fundus camera that day, but it looked like that. So I don't think there's a diagnostic real dilemma here, but it's more of a question around therapeutics. So, obviously this is a patient who has herpetic retinitis. So we did a basic, obviously did full investigations anyway. HIV serology, we did an AC tap. We started her right away on oral treatment with Valtrex and started injecting her with ganciclovir and foscarnet that day. After about a week, we started her on prednisone. So, and then of course the usual eye drops as well. So I wanted to just backtrack here, and we'll go back to what happens to this case, but I really wanted to get the panel's thoughts on how they manage viral retinitis. Now, this is obviously something that's managed by VRS specialists as well as by uveitis specialists. And, there's not a ton of consensus in the literature on what's the best approach, how long to treat, and, should you do oral and IV? Should you do intravitreal? Should you just manage systemically versus ocular. I just want to know, how do you guys manage it, and what works best in your hands? So whoever wants to unmute themselves and chime in.
Take the first stab. Yeah, so I usually do a combination of both. Sometimes if it's very peripheral and a small area of retinitis, and you know that it's HSV or vis-a-vis confirmed on AC-TAP, you could try orals if you have a little bit of time. But in general, I try to clear up the retinitis as quickly as possible. The tricky thing with a lot of these patients, especially when there's so much extensive retinitis, is they're at really, really high risk of retinal detachment. So, obviously the concern is that if you're giving many intravitreal injections in an eye that's already predisposed, does that increase their risk of detaching? At the same time, I do think systemic treatment is a little bit slower than, just throwing everything at them. So I try to clear it up as quickly as possible.
So
I
you
think
put them on oral and intravitreal ganciclovir and foscarnet.
Correct.
Right?
Yeah. Sometimes I find it's difficult practically to get a hold of ganciclovir because there's very few pharmacies that'll make it. The shoppers at UHN used to make it, and now they've stopped making it. So I usually go to Haber's for that. And then Foscarnet, the shelf life is a lot longer. So actually, a lot of these direct-to-physician pharmacies will actually can make Foscarnet for you, draw it out of the bag, and you can store it for 3 months, and you can get many, many Foscarnet syringes from just one IV bag. So that's one thing that's become very helpful recently in the last few years. Also, is there's a Canadian manufacturer for Foscarnet now, so you don't need to go through special access to get access to the drug. So even in the community, this is, I think, something that can be treated more easily now. But as far as the local versus systemic, I usually do both. Yeah. And one thing to add, I know this is a case of VZV, but in cases of CMV, you always want to check PCR in the blood as well too, to make sure that this isn't just local eye disease, that there's not a systemic component to that as well too, because those cases definitely need systemic treatment as well.
Thank you. Ephraim?
Yeah, just to add to that, I mean, Alex mentioned the risk of detachment. That's I think that's very common. I mean, I think it's quoted up to up to 70% of cases. So, I mean, it's almost like you have a bit of a race. You want to get the retinitis treated prior to detachment if it's going to happen, because once the retina detaches, usually there's so many retinal breaks that you need to use silicone oil. And once you use silicone oil and the eyes fill with silicone oil, then you're stuck because you can't really do full dose of intravitreals. You have to like half or quarter dose it. So I think, these cases really are one of our, big emergencies. You have to treat them pretty aggressively with, injections, say twice a week, Foscarnet ganciclovir, or at least one of them if you can get them. I do think that, Xilium, for example, does supply you for like 3 months, and it's not expensive for the patient. So it used to be a big hassle. Now it's pretty easy to get the medication. But generally, I think, when I get these referrals, usually there's a detachment question or it's looming, and you have to be very careful. Either you can treat them prophylactically with laser, and that may be something else people can comment on, or just watch them carefully, because I sort of have the experience that the minute you think the retinitis is almost finished and you're on your last injection, they detach. It's like every time it's right at that timing. It's like, I think one more injection and then we're done, and then next time they come back, they're detached. So anyway, yeah, thanks.
Yeah, I agree with everything that was said. The one thing that's slightly different is I tend not to inject ganciclovir if I have them on orals, because I think the mechanism of action is pretty similar in terms of oral valacyclovir and intravitreal ganciclovir. So I usually will put people on the oral form just to prevent contralateral involvement. The last thing you want is something like Barn. And then I inject them with the Foscarnet. As both Alex and Ephraim said, a lot of it is like accessibility, and nice now that Foscarnet has a long half-life. I did work with a pharmacy to see if maybe potentially ganciclovir could be made with a long shelf life, but unfortunately, because of pH issues, it forms crystals. So we were never able to get it beyond about 3 to 4 days before forming crystals. So just for practical reasons, Valtrex orally, the ARN dose, like you said, a double dose, followed by 1 gram TID, as well as intravitreal Foscarnet twice a week. And I find that works. And again, as Ephraim said, these people tend to detach not in the acute phase, but I guess as the vitreous starts to consolidate, some traction develops, and then the question becomes whether to apply prophylactic laser to prevent retinal detachment. It's a tough one because, on one hand, if you do any kind of procedure and they develop a retinal detachment afterwards, you might get blamed for it. And the evidence, I think, is equivocal. So sometimes if it's a small area, it's a little bit easier to justify barricading it. But if it's quite extensive, 360 degrees, then you wonder whether you're going to apply laser and get a more posterior break.
I mean, I'll take a contrarian approach. I mean, I usually treat these patients just with oral prodrugs. The bioavailability is quite good. I mean, with CMV, there's a good trial that shows that valganciclovir is as good as IV ganciclovir. And even with relatively widespread disease, I find they usually settle down. You can't panic and start injecting too early. With regards to the laser, there's always been a concern about exactly where you apply the laser. And sometimes the areas of retinitis that you see is not actually the leading edge of the infection. And there's a tendency to treat too anteriorly. At least, you might think that clinically you're in the right spot, but then there's actually disease posterior to your laser barrier. And then from a practical standpoint, to do good 360 laser, it's not insignificant. And you're oftentimes lasering in an eye, especially with ARN that has a fair degree of vitritis. So the application of laser is probably going to be somewhat compromised.
And
so
probably
hold off on a
pro-inflammatory
laser
as well.
barrier.
The laser will also be pro-inflammatory too as well. Deepa, do you have any thoughts?
Yeah, I wanted to bring up a related condition. So I've had several cases in the last 2 years where there's whitening that appears in the macula of an older patient. So it looks like CMV, but it could also be a cilioretinal artery occlusion or some kind of artery occlusion sparing the fovea. And I like once, I thought I was treating a CMV, it ended up being artery occlusion. And once I was like, oh, it's definitely an artery occlusion, it ended up being CMV. So I wanted to ask the panel, how much do you trust an AC tap viral PCR? So if the PCR is negative, then do you absolutely not treat whitening in the macula? Or do you just go again clinically? What do you think the presentation looks like?
Who wants to take that one? I mean, I think, from my opinion, if the AC tap is negative, it doesn't rule it out. It's really helpful if it rules it in. So if it's positive. But if the AC tap is negative and you're not sure if the disease is viral or not, I think imaging would be really helpful, like a fluorescein and autofluorescence, because I think a cilioretinal artery occlusion or, versus infectious uveitis should look a little bit different on imaging. So I would hopefully they would on imaging. That would help make the decision as to whether they need treatment, because it's not a small thing to have lots of intravitreal injections for viral retinitis.
Mm-hmm.
The other thing is, I think it's important to repeat the viral PCR. I mean, I think the sensitivity is pretty high for at least the kits that are done through our teaching hospitals. I think it approaches 90 to 95%. But if it's negative, I would just repeat it a second time. The other thing is the other way around. If you have something positive and you have them on treatment for a long period of time and it seems either not to be responding or seems to be having a protracted course, repeating it again should be something on your radar. I had a patient who was being treated for HSV 1 ARN, and it looked a bit unusual, and repeat testing was negative, and it turned out to be toxoplasmosis. So it was an unusual presentation for toxoplasmosis, but you can kind of get into this situation where you just you keep treating, and I think it's important to repeat the diagnostics at time.
So, and I think the other thing on the note too is if they're CMV, you can do quantitative CMV PCR. So you can actually ask them to do the number of counts of CMV. So that's another way to be able to track, is the disease actually going, I mean, sure, you're just checking it in the aqueous versus the, posterior, the disease is posterior, but it is helpful to look and see what the aqueous counts are. Have they actually come down to zero? So that is available.
You could do that for HSV and VZV2. They don't have like a standardized kit to tell you the number of replica copies, but you can get the cycle count. So
Yeah.
the cycle count is the amount of times it has to be replicated before it's no longer present. And I find that helpful. I have done that in some patients with HSV2 ARN, which can grumble on for a very long period of time. And it's a nice thing to see the quantitative levels decreasing. It kind of gives you an idea of when you're close.
Yeah, PCR is really comforting when it's positive, but it's not always positive. Sensitivity isn't 100%. And I think Panos and I shared a case probably last year where we had a youngish guy who was healthy, who came in with a fair bit of vitritis, had an area of retinal whitening, some evidence of vasculitis. And we tapped him twice, his aqueous for viral PCR was negative both times. We gave him a course of treatment both for toxo and for viral retinitis. It didn't really clear. So I ended up taking him to surgery. And then by the time he came to surgery, he just had this sort of burnt out retinitis without a definite chorioretinal scar. And we sent the vitreous for toxo PCR, which was negative. But then in speaking to the ID specialist, the microscopy ended up being positive for toxo. So sometimes you never know.
That's true. I mean, they can look quite similar, even though in the textbooks they look very different, but in real life there can for sure be an overlap. So I think my treatment approach is probably a little bit more like Alex's. I do everything and I throw the book at it. This particular patient required twice a week injections for 12 weeks, so much longer than the traditional kind of textbook duration of 6 weeks, and then we went down to once a week and then injected her for another 6 weeks. She actually recurred when we tried to spread it out further, and so she remained on Valtrex 1000 BID for a long time and then tapered. She still is on Valtrex 500 once a day prophylaxis dosing, and she's now 3 years out and she's not had a detachment, and she's actually 20/40 after cataract surgery. So she did develop, which I think I have another picture of, she did eventually develop, she had ischemia because of the vasculitis. So we did a little bit of PRP. This is well after there was no recurrence of any retinitis, just in the ischemic retina, because we started to see that she was having some like NV-like changes in the area of the ischemia. She actually reconstituted her ellipsoid zone and recovered her vision, which you can see from 2022 to 2025. So I find personally, I tend to treat for a long time. I actually seem to always have at least 3 patients that are running with viral retinitis in my clinics at any given time. And I tend to do extended treatment regimens with injections until they're quiet. And I do find, knock on wood, I'm going to say this now, but I have not had a patient detach in a long time. But it is a good point what Panos is saying about do I need to do ganciclovir and foscarnet if they're on oral already? But so far I have been, and again, this is I think an area where there isn't really a great consensus in the literature. Absolutely, there's literature showing that oral treatment is non-inferior. But I do feel that the detachment, and there is also literature showing that the detachment rates are less with foscarnet. So personally, I have done oral and intravitreals, and I will treat them until twice a week until there's very little left, and then go to once a week. And then after that, I will see them every 2 weeks. And the moment there's a recurrence or something that looks, then they're started again on treatment. And I have a good number of patients that are now a few years out and have not detached and are doing well. They do end up, I find, needing a little bit of PRP laser, not really barrier laser for tear or retinal detachment risk, but rather PRP for ischemic retinal changes, because they tend to get a lot of ischemia even away from wherever the retinitis was. At least that's been my experience. How long do you guys treat for? Oh, sorry, Alan, are you saying something?
Can I ask you a question?
Yeah, absolutely.
Obviously a very precarious situation. Do you prophylax these patients any differently if they need to go for, like when you went for cataract surgery or even other systemic surgery?
For cataract surgery, I put them back to full treatment dosing.
For
They
how
go
long?
back to full treatment dosing. I mean, again, there's no evidence, but I start them about 2 weeks before cataract surgery, and they continue it for almost a month after. I have had, perhaps I'm burned by this because I did have a patient that recurred after their cataract surgery with a fairly significant episode post cataract surgery, and they were on medication, but I had stopped it a little bit faster. And so as soon as I stopped it, it recurred. So now I start them, so they almost get another 6 weeks right around the time of their cataract surgery, and that seems to have staved off any further episodes. But sometimes there may be an early I watch them very closely, and I will start injecting again.
What about if I go for other surgery, like non-ocular surgery?
That's
Do
a
you
good
prophylax them?
question. I mean, I think I would leave that to the discretion of the surgeon and the other physician. Some of these patients, as someone had mentioned earlier, do have systemic CMV, for example, and so then yes, probably they would, as part of their ID specialist recommendations or what have you. But I would defer that to the relevant specialist for that.
I just want to say one thing, just to echo what Ken said, which is I think that a lot of patients can be okay with orals. I think that there's Dr. Bax, you have very hard cases, and I remember being in your clinic as a resident, and I think there is a selection bias, and I think some of the most complex cases find their way to you, and just like this one. But I think I just don't want people to take away from this that, in the community, you can't treat people with orals only, because I think there are, especially milder cases and ones that are found with just small amounts of peripheral whitening that actually respond very well to them. But if you see trouble, you can get a map right down to your clinic over at St. Mike's, because
I think that's a really excellent point.
Some very complicated cases.
We don't need all of these patients sent right away. That's absolutely true. There are definitely patients who have limited peripheral disease that respond to oral treatment, and it has been studied to be non-inferior. I think by the time it ends up coming into the academic core, and or through our ER, through optometry, or through citywide retina call, which is how a lot of them get into St. Mike's. Usually there is some significant severity, or there is some concern about a potential detachment or something else happening. So as you all mentioned as well. But yes, by the time they get to me, I have to throw the book at them. But it has worked well.
Oh, sorry.
Yeah, Larissa.
Just for the general ophthalmologist, I mean, and again, for treating these patients in the periphery, because not everything has to be sent downtown. And I think there's a lot of great pearls from this case, and, specific treatment recommendations that can be done, in the community. I think, first of all, with any uveitis case, it's always important to rule out infection, as we said. The other thing, though, is we see these shingles cases from emerge, and we check them to see if there's any ocular involvement. I think, again, we have to reiterate that you always have to do a fundus examination. These patients need dilated exams as well as the anterior segment exams to see if there's any ocular involvement. And then the other thing that I find is really helpful is when seeing these patients and follow up and determining whether there is any, recurrence or worsening, is to have that fundus image in front of you on the screen. So that may be something that's hard to do in a community setting, but it is very important to helping to follow these patients in a community setting.
And I think another important point is they can do better than we think. And unlike other diseases with uveitis, you can see a reconstitution of the ellipsoid zone, and over time with treatment. You can see this with syphilis too, as for example. And you can think that somebody's vision is going to be horrible, and eventually it comes back. And I remain surprised every time it happens. So I'm going to move on to the next case. So this is a 34-year-old male who's East Indian. He's healthy. He's a mechanic. He had blurry vision and floaters summer of 2024 and presented to the ER, being sent there by his optometrist. His vision was 2200 in the right eye and 20/20 in the left eye. And I'll just highlight the prominent findings. He's got, he's got a lot of eyelashes in the way, but he's got a vitreous hemorrhage. He's got a large area of preretinal hemorrhage with some NV. He's got significant areas of retinal vascular sheathing, and including in the 20/20 eye. You can see temporally and frotemporally, there's a significant area of sheathing here in this eye, and perhaps some hemorrhage in the periphery as well. So here's his fluorescein, and then we'll chat. So clear, obvious findings. There's significant areas of neovascularization and retinal ischemia. And he has these large neovascular fronds in the periphery in both well, much more in the right side, but he has got some smaller ones in the left eye, which is his 20/20 eye. And one can see why he has a vitreous hemorrhage. It sounds like the vitreous hemorrhage is what had him present to the optometrist, and then the optometrist saw all of this and sent him to the ER. So, what are you all thinking? Anybody want to?
Well, similar to the first case, this is an Indian male now. So the first two things you think of are Eales disease and tuberculosis. And you can look and see, are they born in India? Do they have their TB shot when they were a kid? Or have they ever had exposure or recent travel, and sort of fine tune your differential from there. In this case, this does, these are beautiful pictures, by the way, but these pictures are very specific for a peripheral vasculitis, obliterative vasculitis, and, more consistent with Eales, but I definitely would not count out the TB.
So Deepa, can you talk about that a little bit more? How do you, there's obviously an understanding that Eales is also in a way associated with TB. So what is the difference between the two, and how do we make that decision?
So, I think different ID specialists approach it differently. My experience in Toronto differs from New York and Pittsburgh and Buffalo and Windsor, actually, and Detroit. Slightly different. So I'll just tell you what our current ID group in Windsor does, which is they do treat. So of course, we do. I actually don't send them initially to ID until I do like an initial workup. So I do test for TB, and then if they are positive, then I send I do quantiferon gold and then send them over if it is positive. Try to get a little bit of a history, and they do treat. I think every single person that I've sent over do treat, not with quadruple therapy, but they just treat initially if they've had a BCG shot when they were a kid. So if they don't actually turn out to be exposed to anyone with active TB, then they don't treat it aggressively.
Anyone else have
So it's
any
like a
thoughts?
kind of like a screening.
Right. Anyone else have any thoughts on and again, as we said in the first case, we obviously our mind jumps to TB and Eales, but because he's a South Asian man with this peripheral NV. But anything else you'd want to do? What would your next steps be?
So he needs a full uveitis workup. So we do the usual. We want to obviously rule out syphilis. So we want to do an inflammatory. That doesn't look like sarcoidosis, but it's sent for a sarcoid as well. I'd send for other potential causes of systemic vasculitis. So for GPA granulocytosis with polyangiitis, like ANCA testing. Again, this doesn't really look like lupus, but we want to rule that out as well. And I would start with mainly those tests and also refer to, so we have here a situation where it could be inflammatory, it could be infectious, even if it's looking like Eales. So I think the first internal medicine kind of referral would be to infectious disease, but we'd also if we may also want to involve the rheumatologist. And there is, so Eales disease is an immune response to the mycobacterial protein. So we may need to introduce some immunosuppression here as well. And so that's how I would start.
So yes, so this patient was seen by Retina. They did do a great uveitis workup, and the quantiferon TB gold was positive. Chest X-ray was negative. The rest of the uveitis workup was negative, except HLA testing, because the lab sent the wrong tube, so it didn't get done. So that has to be redone. They were referred to me and ID at the same time. They saw ID. ID usually I find, depending on the ID, gives us a hard time when there isn't the typical chorioretinitis. But the ID said, no, there's isolated ocular disease, start the patient on quadruple therapy. And then the retina person did laser, and then I saw them. So at the point that I'm seeing them, they've already been on quadruple therapy for a month. And this is 4 months after the initial presentation. And basically that you can see that there's some PRP in the areas of ischemia, but and I didn't put up the fluorescein, but it looks we did another fluorescein and it looks exactly like the original one, minus that the NV is a bit smaller. So the ischemia looks the same, the vasculitis, or rather areas of vascular dropout, are the same. There's no vitreous or AC cells. The patient is now on TB treatment for a month, no steroids, no topical steroids, so just TB treatment. That's the only treatment that's happened thus far, and the laser, of course. So now what? And this is where I am with this patient. I just saw them this week. Is this actually tuberculous vasculitis isolated? Is this eels and it's an inflammatory response to the TB protein, as we said before? Does this patient need steroids? Do they actually need quadruple therapy? Because maybe this is just the neovascular complication and there's no active infection, and the laser is the appropriate, or maybe some anti-VEGF to shrink the NV, and that's the right call. So this is the conundrum I'm in right now. But usually they're not already on TB treatment by the time I see them, but this patient is, because the retina person managed everything really well. So thoughts, what would you do now? And there's been no progression in 4 months without any steroids.
Is the patient taking their quadruple therapy?
Yeah.
And they're tolerating it fine?
Yeah, they are they're tolerating it okay. A little GI upset or something, but there's no issue.
And how much of the vision has returned to baseline?
Basically, the vitreous hemorrhage has mostly cleared out of the center. So I think the patient is about 20/30, 20/40, so much better. The 2200 was coming from the vitreous hemorrhage.
One thing that we saw in the IVFA is there really wasn't a lot. There was an occlusive peripheral retinal vasculitis, but there wasn't vasculitis in like the posterior pole. It was very minor, retinal vasculitis. My experience is that TB is extremely pro-inflammatory. If you have any kind of active infectious component, you're going to get a lot of late leakage. And personally, like unless somebody has like a choroidal granuloma, the classic serpiginous choroiditis, you wonder whether it's truly TB or some kind of immune-mediated phenomenon as a result of TB. So I think they did treating them just with PRP, I think is very reasonable. I mean, if you didn't have this history, you could look at this case and think it was sickle cell just because there's really just peripheral occlusion and fronds of NV at that, penumbra between avascular and vascular retina. And I don't think there's no inflammation in the eye. I'd probably just perform PRP. The question always becomes whether you treat them for latent TB. I've never seen a case like this treated with quadruple therapy, mostly because ID, I think, says, look, if there's no evidence of true TB, then they tend to just offer latent TB treatment for the positive quantiferon gold. But I'd be interested to hear your thoughts.
So I was of the same mindset as well, but I thought I knew I was presenting these rounds, so I said, let me get all of your opinions before I have to make a stand. But so I left the patient for the last week on the TB treatment, but I felt that there wasn't really vasculitis aside from just leakage in the adjacent area of the ischemic retina. So usually, yes, absolutely TB can present as isolated vasculitis, less common than with chorioretinitis, but there's usually a lot of vasculitis, everywhere, not just at the area of the ischemic retina. So my inclination was to think that the active inflammatory phase, isn't what's going on now, and we're just in a neovascular phase with ischemia.
Can you repeat the angiogram and look for a hot nerve?
I just did. The angiogram looks very similar to this one. I did it last week. I didn't put the images up again because it looked very similar with just the laser in where you see it on the photos. So any other thoughts? So do you think should I tell them to stop the TB meds? It's always harder when they're on it already. What do you say then?
My inclination is to keep, even though it's true the posterior pole is relatively spared, but the patient's tolerating the quadruple therapy, and I'm always erring on the side of caution typically. And the usual hesitation is that the patient does not want to be on all these drugs for that long. So my inclination would be to keep the patient on the drugs if they're tolerating it.
I guess as well, I mean, this is 4 months after the retina person has seen the patient and initiated treatment. So they're 4 months into the quadruple therapy.
They're only 1 month in. They saw ID a month ago. So they're 4 months after PRP initiation and when they first saw them and did the labs, 4 months after. So the two sets of fluoresceins are 4 months apart, but the meds have been for 1 month.
So I would continue because there is a possibility of TB. He's already started this. There's a risk of breeding resistant organisms. I think if you kind of stop and start these medications, and he has positive TB quantiferon, he is positive. It's possible he could develop TB in other kind of areas. I mean, the eye, but other kind of extraocular areas. And I mean, we always talk about, has the patient had full treatment for TB in the past? And we do these workups, and we just, that's one of the questions that ID always asks. So I think he started, I would complete it, do the 6 months. And then he's had full treatment. You've now not ruled out, but you've treated the infectious component, and certainly with TB, there is absolutely an inflammatory component. It's always on the spectrum of how much is the inflammatory component, how much is the infectious component. If we decide there's no active inflammation, then maybe he doesn't need any steroid or other immunomodulatory treatment, but that comes up as well. So I mean, it's not unusual to have the patient start on TB treatment, do of course of oral steroids even, and see whether there's any improvement. If there's definitely no leakage, no active vasculitis on fluorescein, then it's just NV, then maybe that's not necessary, but I would look carefully at the IVFA to make that determination. But I would continue the full TB treatment probably for about 6 months.
Certainly, that's a great point about the steroids. So certainly, I think everybody who has chorioretinitis almost automatically gets started on prednisone as well at the same time, because the significant risk of inflammation down the road. So okay, two votes for continuing. Ken and Panos? Stay or stop or?
I would call the ID staff and I would say exactly what you said. I'd also pop him into the collaborative ocular TB calculator. So there's a calculator where you could put in his age, his whether he's from an endemic area, his phenotype, which will be isolated retinal vasculitis, his PPD, and his chest X-ray CT scan. And if you put that all in, it will tell you, should this patient be treated at all? Should they get latent treatment, or should they get full case treatment? And I could tell you, because I've done this for many, many patients, this patient is going to come back, does not require treatment, assuming that there's no lung involvement. I've actually been surprised because the calculator is very skewed towards if you have a more classic appearance of active TB, like a granuloma and things like that. But what I would do is I would talk to the ID staff. I would give them a copy of the printout from the collaborative ocular TB study. If you enter it all and you submit it, it gives you a printout which says consensus guidelines. It says, and it gives you the level of evidence. And I would send it to them and let them make the decision, because I think it is complicated. The last thing you want is to miss something systemic, or for him to have partially treated or develop some kind of TB resistance. And these ID experts are really, they're experts in TB. They're like TB specialists. And so I think if you were to explain to them that this could be a manifestation of the sequelae of an inflammatory component, that you don't see any obvious overt infectious, and this is the results of the collaborative ocular TB calculator, I think they'd be able to give you a really good opinion. Because although they're tolerating it now, if they get LFT enzyme increases in a few months, or if they start getting some kind of idiosyncratic reaction, you might be kicking yourself, because these things are hard to undergo. These are treatments that are without risks.
Ken?
I don't think I would unilaterally ask the patient to stop his TB treatment, but it's worth having a discussion with infectious disease. And again, I think, if they're basing their treatment on eye findings plus the quantiferon gold, if you explain to them that they're, the eye findings are not really in keeping with active TB, and that this is probably just a vasculitis-like picture, they're probably more likely to agree. And you'd have to watch the patient closely.
Okay, I think that's what I'm going to do. Thank you, guys. This team approach is amazing. So I'm going to just skip ahead to this case, because we just have a few minutes left, which I think this one's a bit more of an interesting one. So this is a a 49-year-old man who presented to the ER. This is one I just added in rather last minute, so you may not have been aware of this case, the rest of you on the panel. So I added last minute because he has very good imaging. 49-year-old man presenting to the ER with confusion, sleepiness, and refractory hiccup. Also said that he had large spots in his vision in the left eye. He was 20/20. So, ER consulted a bunch of services because of these symptoms, and they sent him to us. So at this point, he's healthy otherwise. So this is his fundus photo in the right eye. I'll just highlight that this is not artifact. And this is the fundus photo in the left eye. And he's got this area here, and then a few other changes in the retinal vasculature. And I'll just go back to the other one and highlight another change, because Opto's photos are always a little bit tricky, but there is a occluded vessel that's running through here. And some other areas in here where the vessels are partially occluded in the midst of the vessel. So bilateral areas of arterial occlusion. And this is his OCT, which, pretty good, maybe some early interretinal ischemia here, but not too bad. So, actually, let me show you the fluorescein, then we'll talk. So I saw him, and then we did a fluorescein. So this is the kind of lates of both eyes. So this highlights the important findings. So here's the early of the left eye. You can see that there's a occlusion here, some occlusions out here, and then there's occlusion and some ischemia, and areas of leakage out here, and this little patch of leakage right here. So, any thoughts, everybody, from the panel? Young man, neurological symptoms, arterial occlusions in both eyes. We can save a life once in a while.
We start with our, we obviously want to fully review his systems. Is there anything else that's positive? Does he have anything that's suggestive of Behçet's, for example? So does he have oral ulcers? Does he have any skin lesions? Is there, so what was the full review of systems? And we would want to do a full investigations, including infectious and inflammatory etiologies in this case.
For sure, absolutely. Fortunately, because he came in through the ER and they referred him to multiple specialists at the same time, including internal medicine and neurology. A lot of this was, all simultaneously underway, and he was admitted.
Sorry, why did he come to the ER?
Because his wife said he was behaving very bizarrely. And so she said bizarre behavior, confusion, somnolence, and intractable hiccup randomly. So basically neurological symptoms. So several neurological symptoms, and this notice of spots in the eye, which I believe he was referring to maybe a field defect from the artery occlusions on the one side, but remained 20/20. So
assume
bilateral, yeah.
neurology is going to see him and he's going to get an MRI, presumably. But
Yes.
with encephalopathy and, recurrent artery occlusions, you think of Susac syndrome, which is a vasculitis.
Absolutely. So that is also what I thought. And so this patient has some of the classic findings of Susac in his imaging, because he has the areas of retinal artery wall hyperfluorescence, and he also has the gas plaques along the vessels, which are a little bit harder to see in the photos because of the way the Optos does the photos, but there are several plaques running around through all of this area here. Basically, we sent him back to the ER and said we suspect Susac because he does have bilateral artery occlusions, as well as significant confusion. And even just trying to examine him was quite a production, because he seemed like he was high when we were examining him. So we'll go on to the imaging. So he had MRIs as well, which did show multiple areas of signal change in both multiple parts of the brain and the brainstem as well. And he was diagnosed with Susac. So he had IV methylprednisolone, he had IVIG, then he was put on rituximab, and he fully recovered. So all of the areas, this is several months out. Actually, even within a week, he actually reperfused significant portions of his retina. But within a month or two, it was almost back to normal. He's now about 2 years out. He remains on the rituximab, and he's 20/20, completely normal perfusion. All of the areas of ischemia have fully reversed. He never developed, needed any laser, he never needed anti-VEGF, no NV, nothing at all, and totally back to a normal retina. So just a good case with great imaging, and apparently intractable hiccups is like a very odd presentation for Sussex. So the neurologist wrote it up because of the intractable hiccup being very exciting for a presentation of Sussex. So, so I, I didn't think much of that, but apparently for them that part was really important. Since it's 8:30, I want to just go back and summarize just before. Sorry, does anybody have any thoughts? I know it's a pretty rare disease, but I think one of the times where actually the patient presents like a textbook, unlike all of the other cases. This is actually like a textbook presentation of that could be on an OCAP type presentation of this disease. But does anybody have any thoughts?
It's a great case, Nupra. I have a young patient who has not as bad of a artery occlusion, but a little bit of vasculitis, bilateral small artery occlusions, but completely normal, like professional school, no other symptoms.
Have they had an MRI?
It's ordered, it's not done yet.
Yeah, I think that, that severity within the level of confusion is probably, we don't see them that as much that time because they go to neurology first. Maybe we don't get to make the diagnosis, but maybe your patient we'll see. So in summary, really all of these cases are atypical presentations of retinal disease and uveitis, and multimodal imaging was very important and helpful in many of those cases. And as we saw, always consider infectious or neoplastic causes. If something doesn't respond the way that you expect to treatment, then reconsider the diagnosis because maybe, sometimes these diseases are evolving and how the presentations change over time and what symptoms the patient develops over time can help you lead to the diagnosis even years later. And really, I think critically rely on your colleagues for help, both those within ophthalmology, other specialists within ophthalmology, other specialists even within your same field, as well as our internal medicine colleagues, rheumatologists, and infectious disease colleagues. So I just want to, say a tremendous thank you to all of the members of the panel who took time out of their morning on short notice to join us here today and for sharing their expert thoughts and brilliant pearls. And I hope that all of you were able to learn something to take home and think about the next time you see a patient who has uveitis or an unusual retinal presentation. So thank you very much.
Fabulous rounds, Nupra and Al. It's great rounds, really very illuminating. Thank you.
Thank you.
Thank you for the
Those
invitation.
are great cases.
Thanks, everyone.
That makes
Thank you,
Thanks, Nupra.
everyone.
Thanks, guys. Have a great day.
Thank
Have
you.
a wonderful
good day.
weekend.
Thank you.